Module 13, Chapter 17. Now, when studying the endocrine glands, it's really important that you can get all of the following information put together for each one. For example, you need to know where the gland is located. We do not have currently an endocrine lab in the laboratory portion of the course, so we need to incorporate these anatomical locations into the lecture portion. Likewise, because we don't cover it in lab, you're also responsible for gland structure if I go to that depth with the structure in the module. If I just say where the gland is, don't tell you any specifics about the structure, then you don't need to know any more than where the gland is. Within that gland, you do need to know what cells are producing the hormone or hormones. You need to know what hormones are being produced by those cells. What are the targets of that hormone? So what body parts are being affected by the hormone? And please make a little note for yourself that a target has to be a solid body part. It has to be a cell or a tissue or an organ. It has to be a part. You cannot target another chemical. So please never, never, never say that a hormone is targeting another hormone or a hormone is targeting something like glucose. That can't happen. Hormones can only affect the function of something living, which are your cells, your tissues, and organs. Now, once the hormone gets to the target, you need to know what effects are going to be created by the hormone. Now, that means all of the information that's going to be coming at you is going to be very, very dense. There's going to be a lot of different effects, who's going where, what hormones are acting together, and the lecture notes at this point are going to start to really resemble a textbook with just how much information is present. So what I posted in your Exam 3 module is an organizational table. It breaks this information down for each hormone into columns so that you can have the cells in a column, their hormones in a column, the targets in a column, the effects in a column. It's a way of, one, rewriting your notes, which is key to building those long-term connections and memory, but also taking what could read more like a book, where it's harder to pull out all the information, and put it into a more student-friendly format and have it table organized. So if you decide to do that, what I would recommend is take your notes on the lecture notes as you have been doing. Then get out that table, either in hard copy or on the computer, and actually fill the table in using the notes that you took. Don't take notes on the table because we're going to be adding a lot of other information that's not included in that table format. Now, once you've filled in the table, you can email it to me. I'd be happy to check it over for you to see, are you putting all those pieces together? Are you missing any information? This chapter, if you were to compare it to A&P 1, is at the same level of depth and content as Chapter 14 on the brain. Except we have the joy now of how do all these hormones interact with each other. I would also recommend that you fill in the table as you go, and then you can send me new versions of the table as you're filling in more and more of the hormones. Now, when you're talking about the endocrine system, you do have to start with the hypothalamus, because remember from A&P 1 that your hypothalamus is the integrating link between your nervous and endocrine systems. Now, if you've forgotten this, I would recommend that you go back, review your hypothalamus notes from Chapter 14. Now, with regards to the endocrine functions of the hypothalamus, your hypothalamus produces two classes of hormones that have direct control over the anterior lobe of your pituitary gland. The first class are referred to collectively as releasing hormones. Releasing hormone is abbreviated RH. And as their name implies, releasing hormones are going to stimulate cells to release a hormone. So think of the releasing hormones as an on switch. They're going to come down to the anterior lobe and stimulate the cells there to release a hormone. The second class are referred to as inhibiting hormones. Inhibiting hormones do exactly what their name implies as well. They inhibit a cell from releasing a hormone. So these hormones are going to go down to the anterior lobe and tell the cells there essentially to turn off, to stop producing hormones. So think of the inhibiting hormones as a glorified off switch. So releasing hormones can turn the anterior lobe on, inhibiting hormones can turn the anterior lobe off. Now, in addition to these hormones controlling the anterior lobe, your hypothalamus does produce two other hormones that are going to be carried from the hypothalamus to the posterior lobe of the pituitary gland, and from the posterior lobe be released into the blood. And these two hormones you have been introduced to throughout A&P 1 and 2. This semester you've learned about antidiuretic hormone. You might have heard about oxytocin in A&P 1 if it was given as the positive feedback example in Chapter 1, it being the hormone that helps to run your labor contractions. Now, from the hypothalamus, we land at your pituitary gland. Now, the pituitary gland is inferior to the base of the brain. It's nestled in and protected by the sella turcica. Now, I'm sure you all lovingly recall that the sella turcica was a saddle-shaped bone marking of your sphenoid bone. And in fact, sella turcica means Turkish saddle. Now, the hypothalamus is directly connected to the pituitary gland through a small stalk-like structure called the infundibulum. Now, the infundibulum, as you recall from A&P 1 when you did your brain anatomy, is positioned between the optic chiasm, which is just anterior to the infundibulum, and the mammillary bodies, which are just posterior to the infundibulum. Now, if you envision your blood vessels within the skull, do you remember that lovely cerebral arterial circle? That lovely little circle of bone at the base of the skull, that nice arterial anastomosis. But did you notice in the skull what it was surrounding? That cerebral arterial circle was surrounding the sella turcica. So that means that cerebral arterial circle surrounds your pituitary gland. Now, the pituitary gland has two lobes to it. One lobe is called the adenohypophysis, also called the anterior lobe, which is what I'll be using just for the ease of your note-taking. The adenohypophysis is approximately 75% of your gland's weight, so it's the major portion. It's also referred to as the glandular portion because it has the ability to both produce and secrete its own hormones. The neurohypophysis, which is also called the posterior lobe, is referred to as the nervous portion because it cannot produce its own hormones. Instead, it stores hormones made by the hypothalamus, made by your nervous system, and then when triggered, secretes those hormones into your blood. Now, the anterior lobe of the pituitary gland is controlled by the releasing and inhibiting hormones coming from the hypothalamus. So if your hypothalamus is making these regulatory hormones, how do they get to the anterior lobe? And they're going to move from point A to point B through a unique portal system called the hypophyseal portal system. What's going to happen is the hormones are going to be secreted by cells in the hypothalamus. They're going to enter capillaries, the blood, through capillaries in the hypothalamus, travel through the hypophyseal portal vein, which is in your infundibulum, and then cross from blood in capillaries in the anterior lobe into the actual tissue of the anterior lobe. Now, in addition to the releasing and inhibiting hormone control, there is going to be some control through negative feedback, which is going to come from hormones and other chemicals that are produced by your target cells. So there is some negative feedback also coming in as well. Now, you're going to hear in this upcoming module hormones that end with either tropin or tropic. When you hear tropins or tropic hormones, these are hormones that have the ability to influence other endocrine glands. So these are hormones that can make another gland produce more hormones or not produce hormones. Okay, now when we deal with the anterior lobe of your pituitary, there is a lot going on with it with regards to the cells that are in there, the different hormones that are in there. So you want to make sure that you give yourself plenty of time with the upcoming information. So to begin things, we're going to actually start with the hormone that has the most function, kind of rip off that band-aid, so to speak. We're going to start with human growth hormone. Human growth hormone is abbreviated HGH. It is also referred to as somatotropin. So that tropin, again, is telling you that this hormone is going to influence other endocrine glands. Now, human growth hormone is going to be produced by a specific group of cells within the anterior lobe. These cells are referred to as somatotropic cells. Okay, so somatotropic cells are going to produce your human growth hormone. Human growth hormone is going to enter your blood, it's going to flow throughout the body. One of its targets is actually your liver. And when human growth hormone hits your liver in response is going to produce insulin-like growth factors. Insulin-like growth factor is abbreviated IGF. They're also referred to as somatomedins. Now, insulin-like growth factor is going to prolong the effects initiated by growth hormone. See, growth hormone has a half-life. Okay, remember, a half-life is the time for half of the hormone to be cleared from the blood. Growth hormone's half-life is only about 60 to 20 minutes. However, insulin-like growth factors have a half-life of 20 hours. So we're going to produce this human growth hormone, which is going to cause an effect for about 60 to 20 minutes. However, it's going to cause you to produce IGF, which will then be able to prolong those effects for up to another 20 hours. Now, the most conspicuous effects are going to be on bone, cartilage, and muscle. All right, so now let's talk about the mechanisms of growth hormone and insulin-like growth factor action. The first, which is protein synthesis, is going to be on protein synthesis, is created primarily in your skeletal muscle, cartilage, and bone. And what's going to happen are that these hormones are going to tell the cells in these tissues to increase their amino acid uptake. And when they start bringing more amino acids into the cells themselves start producing new protein. So we're going to increase our amino acid uptake, and as a result, increase our protein synthesis. So we're going to start building new protein. At the same time, these hormones are also going to block protein breakdown. meaning you're not going to be destroying that protein within inside the cells. So what this means is we're going to be building more, destroying less. And the more protein we add to our cells and tissues, the bigger things can be. And if you think about it, it's called growth hormone, so it's going to have an ability to make you bigger. These hormones also target your adipose tissue, and in the adipose tissue, they trigger a breakdown of triglycerides into fatty acids and glycerol. And then the fatty acids and glycerol get put into your blood, which means we're going to have an increase in blood fatty acid levels specifically. Basically, what we've done is we've created in your blood an alternate fuel source, something that your cells can use to make ATP. And because we have this alternate fuel source, the cells of your body are going to choose to use fatty acids for ATP and not protein, which is why this is sometimes referred to as a protein sparing effect. We're going to spare the protein and use the fatty acids for ATP instead. These hormones are also going to affect carbohydrate metabolism. So now, remember I mentioned we're going to have this increase in fatty acid level, and the cells of your body are going to see the fatty acids as that alternate fuel source. So not only will your cells stop using protein for ATP, but they will also stop using glucose for ATP. So the cells in your body are going to start using fatty acids for ATP, which decreases their dependence on glucose for ATP. And what this is going to do is it's going to leave your glucose in the blood, so your body cells are not pulling the glucose out. That glucose is going to then be able to flow to the brain to specifically support brain function. So we're going to be having extra glucose in the blood, and glucose is the fuel for neurons within the central nervous system. There's also a diabetogenic effect that occurs, because not only are we leaving glucose in the blood because your body cells everywhere are not using it, except the brain, but your liver is also stimulated to produce glucose from scratch. Your liver is a little bit of a magician. It has the ability to actually synthesize glucose from non-carbohydrates. So not only are the cells of your body leaving glucose basically in the blood, but your liver is now adding glucose to your blood by producing it from scratch. And as these effects are rolling, your glucose levels in the blood are gradually going to start to rise. And this elevated level of blood glucose is described as a diabetogenic effect. These hormones also have the ability to adjust your electrolyte balance. They have the ability to promote sodium, potassium, and chloride retention by the kidney, and also enhance calcium absorption by your small intestine. Now, if human growth hormone can lead to such a wide variety of physiological effects, you want to make sure that you're producing it appropriately. You want to produce it when you need it. You want to stop producing it when you don't, which is where your hypothalamus comes in. So if you think about hormonal regulation of human growth hormone, your hypothalamus is going to produce two regulatory hormones that can adjust its production. Growth hormone releasing hormone, abbreviated GHRH, will travel from your hypothalamus. It targets your somatotropic cells, and it's going to cause those cells to start to produce and release human growth hormone. So think of GHRH as your somatotropic cell on switch. Likewise, growth hormone inhibiting hormone which is abbreviated GHIH, has the opposite effect. It's going to target the somatotropic cells in the anterior lobe and inhibit their production and release of human growth hormone. So GHIH is the giant off switch for your somatotropic cells. The problem is, how does your hypothalamus know which one to send? That's the question. Because if it has an on switch and it has an off switch, how do you know which one to throw? And that's where your hypothalamus is actually measuring insulin-like growth factor levels inside your blood. So your little hypothalamus, as blood is passing through it, is monitoring the levels of IGF. And it's measuring IGF because the hypothalamus cannot directly measure human growth hormone. So your hypothalamus knows if IGF levels are high, then your growth hormone levels are high, because the growth hormone causes the production of IGF. If IGF levels are low, it knows that growth hormone levels are low. So your little hypothalamus, when it sees high levels of insulin-like growth factor, it makes a decision. Those high levels of insulin-like growth factor tell the hypothalamus, we have enough growth hormone. You need to stop. So your hypothalamus will actually inhibit the production of growth hormone releasing hormone and then stimulate the production of growth hormone inhibiting hormone. So your hypothalamus is going to be told by seeing these high levels that we don't want the releasing hormone because that will cause us to make more human growth hormone. We already have enough. We already have enough IGF. We need to turn it off. And since IGF levels are high, we want to make sure we're not just getting rid of the GHRH, but we want to send out that off switch to guarantee human growth hormone release ceases so that our insulin-like growth factor levels do not get higher. The production of growth hormone releasing hormone and growth hormone inhibiting hormone is also regulated chemically by blood glucose changes. So your little hypothalamus is not just measuring IGF levels, it's measuring blood glucose levels. So let's pose this scenario where your hypothalamus detects hypoglycemia. Hypoglycemia is an abnormally low blood glucose. So what it will do is it's going to release growth hormone releasing hormone and not growth hormone inhibiting hormone. So now that growth hormone releasing hormone travels down to the anterior lobe, hits those little somatotropic cells, who in response release human growth hormone. The human growth hormone then causes the release of insulin-like growth factors. And the effects of HGH and IGF lead to a diabetogenic effect, an elevation in blood glucose, which will bring your blood glucose levels back to homeostasis. Now, what if your wee little hypothalamus detects hyperglycemia or abnormally high blood glucose? Wouldn't human growth hormone and IGF, wouldn't they make this problem worse? I mean, their effects create a diabetogenic effect in the body. Blood glucose is already abnormally high. So what your hypothalamus knows it needs to do is it needs to shut things down. We don't want things to get worse. So we are going to have your hypothalamus send out growth hormone inhibiting hormone and not growth hormone releasing hormone. Sending out GHIH inhibits human growth hormone release. Now, if there is no human growth hormone, the production of insulin-like growth factors ceases as well. Now, if we lose these two hormones, we are going to lose their effects, meaning the cells of your body are going to um, respond in the opposite fashion. For example, your adipose tissue is going to stop breaking down triglycerides because it's not being told to, which means fatty acid levels in the blood are going to go down. If those fatty acid levels go down, then the cells of your body are going to start to use things like glucose and like amino acids for ATP again. In this particular scenario, as the cells of your body start using your blood glucose for ATP again, you're going to see blood levels of glucose drop in turn. Now, before I go on to the next slide, I do want to take a moment and mention diabetes mellitus. Diabetes mellitus stands for tasteful overflow. So the diabetes part is overflow, the mellitus is tasteful. So that means in this particular condition, your blood glucose levels are high, abnormally high, and you have excess glucose being removed from the body in things like your urine, your sweat, the moisture that you exhale, just in an attempt to try to get rid of some of the excess in the blood. Now, most people associate diabetes mellitus with pancreas dysfunction. However, if you think about what you've just heard, it could be a pituitary issue, perhaps a good pituitary tumor, because wouldn't hypersecretion, now hyper always means too much, so hypersecretion means overproduction of a hormone. Wouldn't hypersecretion of human growth hormone also cause diabetes mellitus? I mean, think about it. Human growth hormone causes the production of IGF. These two hormones in a healthy person create a temporary diabetogenic effect, an elevation in blood glucose. Well, what if you had chronically high productions of human growth hormone, chronically, like never turns off? Wouldn't that lead to just high levels of human growth hormone way above normal? And then that would lead to levels of IGF way above normal, and that diabetogenic effect would become permanent and it would worsen. So when you have a patient who has diabetes mellitus, you can't immediately jump to the conclusion that it's an issue with their pancreas and insulin production, because it could be an issue with the pituitary and human growth hormone production. Now let's take a little break and talk about some growth hormone disorders. Gigantism is a disorder where you are going to have hypersecretion of human growth hormone, abnormally high levels of human growth hormone. However, it's the timing. These abnormally high levels are going to hit before and during puberty while you still have the epiphyseal plates in your long bones. Now remember from A&P1, the epiphyseal plates are nicknamed the growth plates because they help your bones to lengthen before and during puberty. Well, if you throw abnormally high levels of glucose at those little plates of cartilage, you're going to have a drastic increase in function at those plates. And you're going to have an individual that's going to have an abnormal increase in bone length, leading to perhaps the statue of the individual here on the screen. Was referred to as the Alton Giant. To record, he is the world's tallest person at 8 feet 11 inches. Now, obviously, this is a statue. The Alton Giants passed away many, 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 many years ago. However, you can see from that statue that he's right next to an average height female of about 5'6". So you can really see what this increase in bone length can do. I also want you to look at the statue and look at the size of the hands with regards to the length of the arms, the arm and leg length with the torso, the size of the feet. And I know it might be a little hard to see, but look at the facial features. Aside from being abnormally tall, the rest of his body seems fairly proportional. Um, and that's something that you need to keep in mind going into our next disorder. Our next disorder, which is acromegaly, is also caused by hypersecretion of human growth hormone. However, it's all in the timing. Acromegaly sets in after puberty, so it's a hypersecretion after puberty. Now, after puberty, you have lost something in those bones that is necessary for you to grow, and that is your epiphyseal plates. At puberty, those cartilaginous plates are replaced by bone, and at that point, your bones have now lost the ability to lengthen. So, for people who have acromegaly, um, they have average height, right? They're not excessively tall, they're not giants. However, there are certain parts of the body that will grow in response to this abnormally high level of human growth hormone. For example, you're going to see the tissues of the lips, the nose, the eyelids, and the tongue start to enlarge. You're also going to have enlargement of the bones in the face, the hands, and the feet, in addition to the tissue surrounding them. So I want you to look at the images here on the screen. This girl at age 9 and age 16 looks like an average girl. However, compare her at age 16 to her at age 33. In the time span between these two images, she developed acromegaly. And if you look at her facial features, you can see that the tissues of the nose have enlarged, her more delicate feminine facial features have enlarged dramatically. And look at the last image of her at age 52. In particular, look at the size of her hands and the size of her chin. Abnormally large. So with regards to acromegaly, you do get this continued growth. It just doesn't affect height because you can't lengthen. Now, if you would like to see an individual that suffered both gigantism and acromegaly, you need to Google Andre the Giant. Andre the Giant was a WWF wrestler back when the WWF was brand new, so back when I was in high school. He was also an actor in The Princess Bride. You might have seen that movie or heard of it. If you actually Google his life, there are pictures that you can find if you dig, and you can see the gigantism develop as he was younger, and then he sort of hit a maximum height, when those epiphyseal plates finally did close. But then, because of the continued production of human growth hormone, he had the development of the acromegaly features in his 20s and 30s. Unfortunately, his lifestyle did more damage to his body. There were a lot of other extraneous circumstances, and he did not live a very long life. Awesome, very funny actor though. Highly recommend watching The Princess Bride, if anything, as a learning experience about acromegaly and gigantism. The last pituitary disorder, the last growth hormone disorder I want to mention is a hyposecretion of human growth hormone. Hypo means too little. So in pituitary dwarfism, you have too little human growth hormone. And what happens is that not having enough human growth hormone before and during puberty drastically slows your bone growth, in addition to causing you to lose those epiphyseal plates too early. So instead of having your epiphyseal plates into your early to mid-teens, allowing you to lengthen at puberty, you lose the epiphyseal plates more when you're 6 or 7 years old. So these individuals tend to have abnormally shortened limbs and very short statures. All right, let's talk about our next anterior lobe hormone, which is referred to as thyroid stimulating hormone, abbreviated TSH. Now, TSH is secreted by thyrotropic cells within the anterior lobe of the pituitary gland. And as its name implies, this hormone has the ability to travel to the thyroid gland and stimulate it. And when the thyroid gland is stimulated, it produces thyroid hormone in response. Now, what will cause your thyrotropic cells to make TSH? Well, they're going to secrete TSH in response to thyrotropin releasing hormone, or TRH, from the hypothalamus. So your hypothalamus can produce TRH, which can travel down to the anterior lobe, find these thyrotropic cells, and tell them start making TSH. Now, please note on the screen that there is no thyrotropin inhibiting hormone listed, and that's because the hypothalamus doesn't make one. So the question is, if TRH basically turns on the anterior lobe, how do you turn it off? And that's where you need to look at the hypothalamus and the fact that the hypothalamus can actually measure thyroid hormone levels. And high levels of thyroid hormone can actually inhibit TRH production by the hypothalamus, and there is some evidence showing that it also can inhibit TSH as well. But the primary mechanism is by turning off TRH at the hypothalamus. So how exactly would that work? Well, let's talk about the green arrows first. If your hypothalamus sees that you have low levels of thyroid hormone in the blood, it is going to cause the production and release of thyrotropin releasing hormone. So TRH is going to travel from the hypothalamus to the anterior lobe and find those thyrotropic cells. The TRH is going to stimulate those cells. They're going to start to produce TSH. The high levels of TSH travel to your thyroid gland, and in response, the thyroid gland is going to start to produce thyroid hormone, which is going to raise your thyroid hormone levels back to homeostasis. So basically, it's a big on switch. However, you don't want this to run forever, because if you chronically stimulate the thyroid with this mechanism, you're going to start to have abnormally high levels of thyroid hormone, and trust me, that's not good either. So how would you turn it off? And that's where we're going to look at the red arrows. As your blood levels of thyroid hormone increase, your hypothalamus sees that too. And when the hypothalamus sees abnormally high levels of thyroid hormone, it shuts off TRH production. So no more TRH being released, meaning no more TRH heading to the anterior lobe. And the funny thing is that your little thyrotropic cells will turn off without the TRH. So turning off the TRH production turns off your thyroid stimulating hormone production. Now, if thyroid stimulating hormone production ceases, there is nothing there to stimulate the thyroid gland, meaning your thyroid gland in turn shuts off. And if the thyroid gland shuts off, no more thyroid hormones are being added to your blood. And this is okay, because if you think about it, your hypothalamus detected high levels of thyroid hormone. This is just going to keep your thyroid hormone levels from getting higher, making things worse. Your next group of hormones are your gonadotropins. Now, the gonadotropins are going to be produced by another group of cells in the anterior lobe called gonadotropic cells. And the gonadotropic cells are going to be stimulated by gonadotropin releasing hormone from the hypothalamus. So the hypothalamus produces GnRH. GnRH heads to the anterior lobe, finds the gonadotropic cells, turns them on so that they start to produce their hormones. Now, the hormones that are made, these gonadotropins, are going to regulate things called gonads. Now, if you have never heard of the term gonad, it's a slang term. It's not actually in any anatomical standard, but it's a slang term for your ovaries and testes. So the gonadotropins are regulating those parts of the reproductive system. Now, there are two different types of gonadotropins, and they're going to have different effects because males and females have different reproductive functions. The first hormone is called follicle stimulating hormone, or FSH. In females, FSH is going to stimulate follicle development and estrogen secretion. In males, it stimulates sperm production. Now, in both genders, FSH production is going to be inhibited by a little hormone called inhibin, which actually is produced by the ovaries and testes. So FSH can be regulated by blood levels of inhibin. The other gonadotropin is called luteinizing hormone, abbreviated LH. Now, in females, luteinizing hormone triggers ovulation, which is the monthly release of a, quote, egg from the ovary. Also, the formation of a temporary gland in the ovary called the corpus luteum. Not only does luteinizing hormone cause the formation of this corpus luteum, but it also stimulates the corpus luteum to produce estrogen and progesterone, your two sex hormones. Now, in males, luteinizing hormone is going to trigger testosterone production. Now, since GnRH from the hypothalamus sort of starts all of this, it has to be regulated. And gonadotropin releasing hormone is going to be inhibited by estrogen, progesterone, testosterone, even a little bit by inhibin. However, the real control mechanism involved is very detailed, and we're going to cover it in chapters 27 and 28 at the end of the semester when we do male and female reproduction. So for now, this is all you need to know. Just be aware that more information on this is going to be coming later. Our next anterior lobe hormone is called prolactin, which is abbreviated PRL. Now, prolactin is secreted by prolactin cells within the anterior lobe of the pituitary. And prolactin, working with other hormones, helps to stimulate mammary gland development and milk production. Now, please jot a little note for yourself that it's milk production, not milk ejection. Milk ejection is actually triggered by another hormone. Now, usually when you think about these functions, it gives a misperception that prolactin is a female hormone, but it can be produced in either gender. Now, your hypothalamus produces what is called prolactin inhibiting hormone, or PIH. PIH is the same exact chemical as the neurotransmitter dopamine. However, because in this instance the chemical is being released as a hormone, not a neurotransmitter, you have to call it prolactin inhibiting hormone. Now, prolactin inhibiting hormone's job is to inhibit the production of prolactin. Now, this is where things get interesting. Prolactin inhibiting hormone is produced in males 24 hours a day, 7 days a week, which means if PIH is there all the time, males don't produce prolactin, period. That constant inhibition is going to keep males from producing prolactin. So without the prolactin, you don't have that extra stimulation of mammary gland development and milk production, which suits their reproductive function. The case is a little bit different for females. In the female ovarian cycle, okay, in their reproductive cycle, prolactin inhibiting hormone levels drop dramatically when estrogen and progesterone levels drop just prior to menstruation. So when estrogen and progesterone levels drop, prolactin inhibiting hormone levels drop too. And with that inhibition removed, your little prolactin cells throw mental confetti and they start producing prolactin like there is no tomorrow. Okay, those little prolactin cells are going, woohoo, I'm not being inhibited, and it starts to produce all this prolactin. Well, that prolactin actually stimulates mammary gland development. Most women, just prior to menstruation, get a lot of breast swelling, which can make the breast tissue very, very tender. And that swelling is actually being caused by this temporary production of prolactin. However, as you continue through the monthly reproductive cycle, your estrogen levels do increase again. And the moment you have your increase in estrogen, your prolactin inhibiting hormone returns magically. And the moment that it returns, prolactin production drops, the breast tenderness goes away, and you're ready for your next cycle to continue. Now, with regards to prolactin releasing hormone, prolactin releasing hormone from the hypothalamus does promote the release of prolactin. However, it's not very well understood. And there is a lot of arguing about it. I have done some extra digging in the scientific literature, and there are arguments on both sides about this hormone. The general understanding, for the people who believe it exists, is that during pregnancy, women start to produce this prolactin releasing hormone. And prolactin releasing hormone is actually going to increase your prolactin production during pregnancy. Now think about it. If you are pregnant, what is one thing you have to do? You have to prepare the mammary glands for potential milk production to nourish your offspring. So prolactin releasing hormone produced only during pregnancy allows you to have enough prolactin to help support that extensive mammary gland development and help to stimulate that milk production. So prolactin inhibiting hormone is present in males 24 hours a day, 7 days a week. It's present in non-pregnant females all the time, except for the little window of time just prior to menstruation where you lose your estrogen and progesterone. Prolactin releasing hormone is produced only in pregnant women, and it's just to boost your prolactin levels to help get mammary gland development where it needs to be. Now, issues with these hormones, with prolactin, could be interesting. If you have prolactin hypersecretion. So you have abnormally high levels of prolactin, because normally you don't have any for the most part. Hypersecretion in males has actually been proven to be a cause of erectile dysfunction, the inability of a male to gain an erection with sexual arousal. In females, it causes amenorrhea. Amenorrhea is a loss of menstruation. It also causes galactorrhea, which is inappropriate lactation. Now, these two effects are in women that are non-pregnant. So this hypersecretion in a non-pregnant woman will cause you to stop menstruating and trigger milk production when you're not even pregnant or nursing. Our next anterior lobe hormone is adrenocorticotropic hormone, which is abbreviated ACTH. It's also referred to as corticotropin. However, I prefer to stick with the ACTH. Now, ACTH is secreted by corticotropic cells within the anterior lobe. When ACTH is released, it's going to travel through your blood. It's going to travel down to the adrenal cortex, which is the outer region of your adrenal gland. It's going to cause your adrenal cortex to produce and release glucocorticoids, which is a group of hormones that includes things like cortisol, your body's natural anti-inflammatory. Now, these glucocorticoids have the ability to modify glucose, protein, and lipid metabolism in addition to reducing inflammation. And we'll be talking about the glucocorticoids to a greater extent in our last endocrine module when we talk about the adrenal gland. So, how do the corticotropic cells know when to release ACTH? Well, your hypothalamus will produce a hormone called corticotropin releasing hormone, or CRH. CRH travels to the anterior lobe, stimulates the corticotropic cells, who in response produce ACTH. There is no corticotropin inhibiting hormone produced by the hypothalamus. So the regulation mechanism here is very similar to the regulation mechanism described with thyroid stimulating hormone, your TSH. Now, corticotropin, your hypothalamus, is inhibited by high levels of blood glucocorticoids. High blood levels of glucocorticoids have also been shown to moderately inhibit ACTH production as well. So let's take that and think about how this mechanism might work. So let's think of this scenario where your blood cortisol levels are abnormally low. And believe it or not, wee little hypothalamus actually measures blood cortisol levels. And when your hypothalamus sees low blood cortisol, it starts to produce and release corticotropin releasing hormone. This CRH travels to the anterior lobe, stimulates your corticotropic cells, who in response increase their production and release of ACTH. The ACTH travels down to wee little adrenal cortex, causing it to increase its production of cortisol. That cortisol is then placed in the blood, and it helps to raise your cortisol levels back to homeostasis. Now, what if your hypothalamus detects abnormally high levels of glucocorticoids? Well, the last thing you want is to produce more. More production of glucocorticoids is just going to push you further out of homeostasis. So your wee little hypothalamus knows, well, if cortisol levels are high, we need to shut things down. So your hypothalamus stops producing CRH. The loss of CRH causes your corticotropic cells to stop producing ACTH. Your blood levels of ACTH decline, and your adrenal cortex stops producing cortisol in response. So in order to turn things on and off, all you have to do is have your hypothalamus recognize, are cortisol levels low? If so, let's turn everything on. If cortisol levels are high, let's turn everything off. The last anterior lobe hormone, and yes, I promise it is the last, is called melanocyte stimulating hormone, abbreviated MSH, also called melanotropin. Now, believe it or not, MSH is made by the same corticotrophic cells that produce ACTH. So at least there's not another group of cells for you to learn. Now, if you think about the name, it tells you what it does. This hormone leaves the anterior lobe, travels to your melanocytes, and stimulates them. Now, in AP1, you learned melanocytes produce melanin, your body's natural UV protectant. However, you also learned that melanin is a pigment, and it's in that, beige to black category. So we've got this nice brownish pigment. So if you stimulate melanocytes, you're going to increase their melanin production, which is going to lead to an increase in pigmentation in the skin. Now, this hormone is not abundant in humans. In fact, healthy humans usually have blood levels that are 0. However, there are certain times when you actually can detect it. MSH is found at detectable levels during fetal development, though the role it's playing there is a little unknown. Pregnant women do have MSH production, which is why pregnant women often develop some unique changes in pigmentation in certain parts of the body, and it's all owing to this increase in MSH. Very young children do have detectable levels of MSH, primarily within the brain, and there are some disease states where you would have hypersecretion of MSH. Now, corticotropin releasing hormone does stimulate MSH production, just like CRH stimulates ACTH production. However, there's a catch. CRH has to be at excessively high levels in order for MSH to be produced. In a healthy individual, these levels are usually never reached. However, during disease states, during pregnancy, when hormone levels are high overall in the female because she is gestating this fetus, these particular situations can lead to higher levels of CRH. Now, dopamine, which is that prolactin inhibiting hormone, inhibits its release. And what did you just learn about PIH? It is produced in males 24 hours a day, 7 days a week. In non-pregnant females, it's produced all the time, except for that really tiny window right before menstruation when you have low estrogen and progesterone. So for the most part, you have got the inhibitor of MSH production present all the time, which is why in humans, healthy humans, it's usually 0.